Hi everyone, we're going to move on to Unit 7, which is communicable diseases, and I'm super excited because this is one of my favorite topics. So we're going to get going with part 1. So for communicable diseases, we're going to first talk about some general concepts, including the burden, routes of transmission, how we figure out what's causing them, and their potential impact. Then we're going to go into the public health tools that we have to control or eradicate or otherwise deal with communicable diseases, and then talk about our different strategy options, which are basically elimination or just control. So what is the burden of communicable diseases? And some of this you already know from our lecture on non-communicable diseases. It should look pretty familiar. So this is looking at mortality rate on the left and disability adjusted life years on the right. And you can see, if you remember, the things in red for the most part are our communicable diseases. And we can see that when it comes to causes of disability and premature death, they're an even bigger piece of the pie. Pretty sizable for both, though. When we look at leading causes of death globally, so mortality or deaths, you can see that those lower respiratory infections are number 4 on the list. So those are pneumonias for the most part. And neonatal conditions are at number 5. These are illnesses, infections that kill infants, right? So this is a huge problem globally. And then you can also see that diarrheal diseases also make the list of top 10 causes of mortality. I want to point out to you the difference between the different circles because it's kind of neat to see. An open circle is the data from 2000. A closed circle is 2019. So what we can see actually is that lower respiratory infections have gone down. Neonatal infections have gone down in terms of the numbers of deaths in millions they cause in that year. So have diarrheal diseases. So we're making huge strides in controlling these diseases, which is amazing. Now, you might have noticed, oh no, ischemic heart disease, which is heart attacks, has gone up, and stroke has gone up. And so then you'll probably remember me telling you that everybody has to die of something, and that if you're dying in old age, you are likely dying of a heart attack or a stroke. So unfortunately, we can never decrease the total number of deaths. We can just decrease certain causes of them and hopefully decrease premature deaths and certainly decrease suffering. So if we look specifically at the different types of diseases that cause mortality on the global level, again, there are those lower respiratory infections. HIV and AIDS is still a major killer in many parts of the world. Here are those diarrheal diseases. You'll notice this is an old chart, which is why it's a little bit different from the other. And that tuberculosis, which we in the United States don't often think about unless we live in an urban center, and malaria are also really big killers at the global level. We also need to acknowledge the difference between lower socioeconomic development and higher socioeconomic development countries. So the countries with lower socioeconomic development, as we know, are going to have a much larger proportion of their causes of illness and premature death be due to communicable diseases or infections. We also can't get too cocky. So infections can also cause significant mortality even in developed parts of the world. So this is actually global data looking at excess deaths that have occurred during the COVID pandemic, for the most part due to COVID-19 itself. And this is a little bit more about how those excess deaths are measured. So this is data from the United States collected by the CDC. They do this all the time. So they collect how many people in our country died every single week. And so what we can see here is this particular graph starts in January of 2017. And you can see that there's this kind of, every summer it goes down and then every winter it comes up, and every summer it goes down and every winter it comes up. And a lot of that seasonal variation that we see in deaths that occur in our country are due to influenza, actually. So it does cause a significant number of deaths in our country every winter. There are also some other conditions that are more commonly fatal or more commonly occur in the wintertime. You can see then that this is pretty predictable over time. Things don't change a whole lot generally from year to year. You might have noticed that in January of 2018, we kind of went above what the expected threshold would be. We had a particularly severe influenza season that year, so that makes sense. As we come along to more recent times, then you can see here's January 2020, and here we go into May. And so we start to see this huge surplus, this huge number of increased deaths beyond what we normally see. So on the next slide, I'm going to show you kind of a more recent version of this same graph. Before I do, because I see it's on here, most of these excess deaths were due to COVID infection itself. Some, however, were due to overwhelmed health systems. For example, in New York City, when COVID first struck and there were massive numbers of cases and there was panic and nobody knew what was going on and it was really scary, emergency rooms and hospitals got overwhelmed, and there were also overwhelming numbers of severely ill people. What that meant, for example, is that the Fire Department of New York, which runs the EMS ambulance service for New York City, normally gets maybe about 3,000 911 calls a day that they have to send an ambulance out for. During the initial pandemic wave in New York City, they were getting more than 7,500 calls for ambulances a day. They didn't have enough. And so in fact, the FDNY worked with national organizations that do telehealth with physicians and had physicians help take 911 calls to help triage whether they really needed an ambulance or not. So I have a friend who's a physician here in Wisconsin who literally took 911 calls from New York City because that's how bad the problem was. So there were lots of people, unfortunately, in New York who called for an ambulance, but it never came, or it took it over an hour or 2 hours to come because there just weren't enough ambulances, or by the time they got to the emergency room, it took hours before there was any doctor who could see them, even though they were in the middle of a heart attack, right? So we also had some excess deaths due to overwhelming the healthcare systems. So this chart takes us all the way up to now kind of our current time, and you can see that through most of the time ever since the pandemic began, we have been seeing more deaths in the United States than we typically do in any given week. Again, the vast majority of these are due to COVID-19 infection itself and its complications. Some of them, especially during the peaks when things get really hairy and busy, are going to be due to overwhelming medical capacity. And so then people die from other things that they wouldn't necessarily have died from. You might think, well, how do we do in Wisconsin? So you can also filter by state. So what you see in the lower graph is Wisconsin, and you can see that proportionally we've been a little bit spared compared to the country as a whole. Although last winter, right, we had that big spike that came before the big national spike, right? We were the early leaders on that. And you can also see that here in Wisconsin now, we are starting to be an area of significant increased deaths, proportionally more than some other places in the country. Another way to look at this as causes of death daily, and this one does it by cause, right? So this is by the diagnosis that was the contributory cause of death, right? The thing that actually killed the patient. And so you may remember from our non-communicable disease lecture that heart disease, which is this green line right here, is one of the major causes of mortality in the United States. And number 2 right here is cancer. Okay, and those are pretty steady in general. And then the purple line here is deaths from COVID, right? And so these were new and on top of all the deaths that we normally see. So let's think for a minute about who is most at risk of getting communicable diseases, right? So we talked about the burden and how they can cause a lot of deaths, they can cause a lot of disability. And we saw that in countries with low socioeconomic development indices, that they are much higher risk of communicable diseases. And that has to do with lack of sanitation infrastructure, health services, educational systems, other things that can be really impactful at preventing or controlling or treating or even eradicating a lot of these diseases. So when we talk about our toolkit, we'll talk about those things at more length. Within an individual population, however, in general, and this is not always true for every single infection, but in general, the people who are at highest risk from infectious diseases or communicable diseases, infections, are going to be the very young people, so infants and small children, because their immune systems are still developing and they don't have immunity to many things because they haven't yet been exposed and because they haven't yet had all their vaccines. Also, the very old. When we get older, our immune systems start to kind of not work quite so well, just like maybe our hearing and our vision start to not work quite so well. So both ends of the age spectrum tend to be at higher risk. Those who have a compromised immune system for any of a variety of reasons, it could be a condition they have, it could be medications that they're on to treat another condition, like maybe they have an autoimmune condition or they're a transplant recipient. People who are pregnant, interestingly, are often at increased risk of having worse outcomes from certain types of infectious diseases. And certainly people with other medical problems. So depending on the infection, if you have some other medical problems, that might make it that much worse for you. And as we've talked about before, people with poor social determinants of health. So if you live in a state of chronic stress, you don't have good nutrition, all of those things are going to impact your ability to do well should you be exposed to a communicable disease. So when we talk about these groups of folks, we usually talk about them as our vulnerable population. So pregnant, infants and children, elderly, and the one thing missing from this graphic would be people of racial and ethnic minorities and low socioeconomic status, because they tend to have poor social determinants of health. So those are our most vulnerable members of society, and we'll usually see with any communicable disease, as with many non-communicable diseases, that their rates of bad outcomes or of getting these things is going to be higher. So let's talk about routes of transmission, which is basically how do you catch this disease, right? How do you get that germ? So you could get it from a tick, right? We all know you can get Lyme disease from a tick bite. You can get other diseases from ticks as well. It could be from a mosquito like malaria or dengue or West Nile virus, for example, those things. So those are vector-borne illnesses. They are transmitted by insects. In both of these cases, these are insects that suck our blood and inject saliva into us, and so they can carry an infection from one human to another. Sometimes we can get infections from animals. So rabies, for example, is something that can be transmitted to humans by the bite of a bat or several other types of animals. It could be airborne. Now, this is the one that we all know a lot about, right? Or fomites. So let's just talk about that. So airborne means that the infected person is coughing or sneezing or breathing out particles of this germ. It's often a virus, but bacteria can also be spread this way. And then the potential host in this diagram is the not yet infected person that breathes it in or gets it on their eyeballs, and then the germ gets into their body. So within that category of airborne, there's kind of two subdivisions, whether they're aerosols or droplets, and COVID tends to do a little bit of both, but more droplets than aerosols. But anyway, and then fomites. So that's a really funny word. Fomites basically mean an inanimate object. So a contaminated surface. So for example, if I have a common cold coronavirus, I cough into my hand and then I grab a doorknob and then you come in and you touch that doorknob and then you rub your eye, right? So transmission via a surface, an inanimate object. And what we've learned is initially we thought fomite transmission might be important for COVID-19, but over time we've seen it's not actually a major mode of transmission for this particular germ. Sexual activity, I don't think you need a picture from me for that one, but that can definitely transmit certain types of infections. Water and food, right? So water and cholera, you're very familiar with, hopefully by now. Food, hepatitis A is often spread via food. So those are things that you can get because of you ate or drank something that was contaminated. Fecal oral transmission. So this is why we want people to wash their hands after they go to the bathroom. So things like salmonella and polio can be transmitted if you get a little bit of poop particles. Just doesn't take much, just a little tiny bit, and then you kind of touch a doorknob and somebody else touches that and then they bite on their fingernail or something, then it can spread. So it's not lovely to think about, but there are a lot of infections that spread that way. Bloodborne, so that means you need some type of contact with one person's bloodstream and somebody else's bloodstream. Hepatitis C does this. There are some other things. Most commonly, kind of in the real world, the way that happens is through injection drug use and people sharing needles one to the other. That will carry the germ from one person's bloodstream to another person's. HIV can also be transmitted this way, which is why blood that is donated to blood banks always gets screened and tested for that. And then there's vertical transmission, which means from mother to child in utero. So while the fetus is inside the uterus, growing in the mother's womb, she can pass certain infections to the unborn child. So in this funny little diagram here, right? So during pregnancy itself, and it can occur. Sometimes during the process of labor and delivery, there's some exchange of body fluids and blood that can happen. And then after birth, breastfeeding can also transmit certain infections. HIV is one of those, interestingly. So lots of different ways you can get germs. Those are our routes of transmission. So how do we identify which germ is the culprit? How do we identify that contributory cause of a particular communicable disease? So the famous scientist who elucidated these principles was Dr. Koch, and he came up with a whole list of things, and we're going to kind of do an abbreviated and modernized version of that. So keep in mind that in terms of potential pathogens, and pathogen is the fancy name for a germ, you can have bacteria, you could have viruses, you could have parasites like lice or scabies, or you could have prions, which are these weird little protein things. So there's lots of different categories of potential germs out there, some of which are large enough that you can see, some you can see with a microscope, and some you need a super duper crazy microscope to see. So anyway, these criteria to establish that a particular germ is in fact the cause of a particular disease are: you have to see at the group level an association between the presence of that germ and the presence of the disease. So if you remember back to talking about distribution of disease and looking for group associations, you're looking to see in places where there's more of this germ, do they also have more of this particular disease, and vice versa. So that's that epidemiologic association, not looking at the individual level, but that group association level. Then you also need to find it at the individual level. So in a person who has the disease, and most people who have the disease, are you able to actually find evidence of that germ? Now that seems pretty basic and simple, but if it's a germ that humans have never discovered before, and we don't know what we're looking for, that can be really tricky. So that was the case with Legionnaire's disease, actually, and that was a hard one to grow in the lab. So it took them a long time to figure it out. It was very scary. Now, here's the thing I want to warn you about. So in the book, I'm using some of the language from the book for consistency. So they talked about the ability to isolate the pathogen in most people with the disease. So to isolate means to find. And so I find this a little confusing because the word isolate is used in two different ways in this unit. In this context, we're talking about the ability to find the germ and recover it and pull it out, the ability to isolate it from an infected person. But in other contexts, isolate is going to refer to isolation. So taking an infected person and making them stay away from other people so they don't transmit the germ to them. So just be careful when you see the word isolate and make sure you know which meaning applies to that situation. The last one is you want to demonstrate transmission of the disease occurs with transmission of the pathogen. So historically, the way this would be done is that a scientist would take the germ and inoculate it, give it to an animal, and see if the animal got sick then, right? Yeah. Okay, so association at the epidemiologic or group level, isolation, finding it in the people with disease, and then the fact that then you see that transmission of the pathogen transmits the disease. All right, so our last section of part 1 is going to be what's the potential impact of any given communicable disease? How bad can it be, right? How worried do we need to be about any particular infectious disease? So that's going to depend on two things. One is how serious is the actual illness when you get it? And we can look at that through your case fatality rate. We can look at that through hospitalization rate, what percentage of people who get the infection get hospitalized. We can also look at what types of disability does it cause. Are people homesick in bed for several days? Are people homesick in bed for several weeks? Do people develop long COVID and are really disabled for several months, right? And then also long-term complications. So how serious is the illness? And then how contagious is it? So I'm going to talk the next several slides. We're going to talk about how we assess and describe how contagious something is. So before we kind of get into the nitty-gritty here, I also want to clear up the fact that contagious is the same thing as transmissible, is the same thing as infectious. So those words will often be used interchangeably. I do want to point out that the word infectious means contagious, and it is different from the word infected. So you can be infected with something and possibly not be very contagious, right? So those are two different things. It's kind of subtle, but if we're talking about how contagious you are, that's the same thing as how transmissible or how infectious. So the way we measure that is with a number that we refer to as R naught, or R with a little sub-zero. And that is the number of people on average that an infected person will end up giving their disease to, right? So if I have a certain infection, on average, how many people am I likely to transmit that infection to? So for measles, it can be really high. It can be 10 to 18 or 20 other people for every one person. They infect a ton of people around them. HIV, it's usually about 5 to 10 other people. Okay, so this is a way that we talk about how contagious a particular illness is. How many people are you going to spread it to? So let's take a look at how this plays out. So if I have an R naught of 2, for example, that one person is going to infect 2 people. Those 2 people are then going to each infect 2 people. So now I have 4 people. And then each of those 4 people are going to infect 2 people, right? So now I'm going to have 8. And it goes so on and so on and so on. And you get this doubling effect that happens. Now let's look at an R naught of 5, or a reproduction number of 5. So here I go from 1 to 5 to 25 to 125, right? So it goes really, really quickly. So let's look at this in a slightly different way. And I just realized that first graphic is wrong. It should end up with 8 in the next iteration. Okay, so I overlapped my graphics. My apologies. So this first graph is if the R naught is 2. And you can see if it takes a week on average for me to infect you, and then you can go on to infect somebody else, if that time in between each one, if it takes about a week to take, then in the first week I would have 2 or 1, second week I would have 2, third week I'd have 4, 5th week, now I have 8, then I have 16, then I have 32, 64, and then I'm up at 128 at the end of 2 months. But if the R naught is 5, look at this. I get to over 120 in half the time, 4 weeks, okay? With that, continuing to just increase and increase and increase. So these are these epidemic curves that we often see, and we've seen a lot of this past year with infections. So what are the things that determine the R naught or the reproductive value? What determines how contagious something is going to be? Well, a lot of it is the pathogen or the germ itself. Some germs are really contagious because when you get them, they make lots of copies of themselves, and then they make lots of copies of themselves that get sneezed out or spit out or coughed out or breathed out, where they can easily infect other people. Some germs might get into my bloodstream, but maybe they don't make very many copies of themselves, and then who else is really going to come in contact with my bloodstream, right? So it's not just how many copies of the germ get made in your body, but also how much you're spewing them out into the world. So the germ itself is going to determine those things. The other thing that's going to impact R naught is mitigation measures and human behaviors. If I'm infected, but I'm wearing a mask, the R naught is going to be lower. If I'm infected, but I stay home and I isolate away from others, the R naught is going to be lower. We also see this with sexually transmitted diseases, right? So if I happen to get an STI, but then I always use condoms, well, I'm not going to spread it to anybody else. Maybe that was just that one whoops, right? Or if I only have 2 sexual partners, I'm only going to spread it to 2 people. But if I have 20, I might spread it to 20, right? So human behaviors on the mitigation measures that we do or do not utilize are going to have a huge impact on R naught. And so in the book, this is all going to fall under the category of barriers, and that's one of our tools in our toolkit. And it's a really diverse array of different tools within that category. And then the last thing that's going to impact R naught is how much immunity do we have in the population. And you can develop immunity due to a history of previous infection, sometimes depending on the germ, and due to vaccination if there's a vaccine available that is effective. So the thing to keep in mind, and this is going to come up again when we talk about vaccination as a tool, that's another tool in our toolkit, is that you usually need a very, very high level of immunity in a population in order for it to have any impact on the ability of the germ to spread within that population, right? If I only have a smattering of people with immunity, then the germ is like, no problem. There's plenty of other vulnerable people out here for me to infect. And so we're not going to see a big difference at all at population level numbers of cases or at R naught unless the immunity level gets really, really, really high. The other thing about this that's kind of a bit more advanced, but is it needs to be a specific type of immunity. So it needs to be what's called sterilizing immunity, which means the germ can't even infect you to really impact transmission. And some types of immunity do that and some don't. It depends on our immune system, it depends on the vaccine, if there's a vaccine involved, and it depends on the type of pathogen. Sometimes it's not really possible. So if you want to know how quickly something is going to potentially spread through your population, the 2 factors you want to know are the R naught, how many people does each infected person tend to give their infection to, and then how quickly is that turnaround time? How fast is that turnaround time? And so this is a new concept. So this is the latent period. So I'm going to show you what's happening on this graph down here. This is the day that I get infected with something, right? That's the day that somebody coughs in my face, for example. Now, what's going to happen is that for several days, that germ is just going to start replicating in my body, but it's going to be at really low levels. Eventually, it's going to get to high enough levels where I am communicable, right? Where now I can give the infection to other people. And then a short time after that, there's going to be enough of it in my body that I'm going to actually have symptoms and have disease. Okay, so depending on how long this latent period is, right, that's telling me kind of my turnaround time of how quickly this can get transmitted from one person to another, and then how quickly that person can turn around and transmit it to somebody else. So that latent period is going to be pretty important when you want to figure out how quickly can something spread through a population. So how does COVID-19 kind of stack up in terms of some of these factors? So the original virus, which was pretty much all we had for about the first year of the pandemic, had an R0 of 2.5. So on average, an infected person infected 2.5 other people, right? And then each of those infected 2.5 people, and so on, and it exponentially grew. The latent period was about 4 days on average. I'll show you what this looked like. So you first get infected right here, but there's so little of the virus, it hasn't yet really started replicating, that it's not detectable until right around here, and it doesn't get high enough till you can start giving it to other people until right here. See how this says infectious in purple? This is your infectious period. And one of the really tricky things about SARS-CoV-2, which is the virus that causes COVID-19, is that people were infectious for 2 days on average before they even started showing symptoms, like pretty highly infectious. And this was hard because they don't know that they're potentially sick, and so they're still going out and seeing their friends and kissing them and sharing drinks and doing all those things because they feel fine. Right? So that's why COVID has been really, really tricky to control. Influenza, on the other hand, the period of infectiousness, of being contagious, is pretty closely linked to how miserable you feel and how bad your symptoms are. So the nice thing about influenza is that for the most part, you're most contagious when you feel the most miserable, which means you're probably at home in bed and therefore not out and about and giving it to other people. So anyway, this was the original OG virus, but as you know, we've had a lot of variants since then, some of which are evolutionarily fitter than others. So the Delta variant, for example, the R0 is about 6 or so, and so it was able to spread much more than the original virus, which is why it's given us such a run for our money ever since this summer. And now we have Omicron. Now, this is kind of tricky to figure out because, as you know, how fast something spreads through the population depends on both the R0 and the latent period. And so we're trying to figure out both the R0 and the latent period at the same time. So we think maybe the R0 for Omicron is 10, which, if you can imagine, you go from 1 to 10 to 100 to 1,000. And the latent period is maybe 2 to 3 days. So you do that every 2 to 3 days. So can you imagine? Well, we don't have to imagine, we're in it, right? So this is new daily confirmed cases per million people. And I've shown you the United Kingdom because they have a lot of characteristics that are very similar to the United States, although they're different in some important ways. The United States is in green, and the European Union, as just another example of highly developed countries, is in the pink. So this is the original virus, and it really caused a lot of cases, a lot of surges, a lot of illness. That got a little bit better. And then the alpha variant came on the scene and was a little bit more contagious. It had a higher R0, and so we saw another surge in some countries more than others. And then the Delta variant came along. And so Delta, you can see the United States in green, really became a significant force this summer into this fall and has continued particularly in Wisconsin. We really didn't get going with it very much until October, November, December. And now, of course, we are all dealing with Omicron. And this is really just breathtaking and in a horrible way. If you look at the extent to which the number of Omicron cases is absolutely eclipsing the numbers of cases we ever saw from any of the other variants, right? So none of the others did we ever even get to a daily count of 1,000 per million people. And United Kingdom, who's a little bit ahead of us with their Omicron surge, is now over 2,500, right? So 2.5 to 3 times as many cases, and in absolute rapid fire fashion, right? So this is just insane, actually. So here's Wisconsin again. So if we look specifically at our state, here was kind of the original virus, the Alpha surge, which was not big here, and then Delta, which has been giving us headaches all fall and has been filling up our hospitals, particularly this November, December, and January. And now on top of it, we have Omicron. So it's either got a really high R naught and or a really quick latent period, probably both. So you might say, well, but I heard it's less serious. Yes, there is good evidence to indicate that Omicron causes a less severe illness, which is really good news. But the problem is there's so much of it. So what we're seeing on the left is those cases per day in Wisconsin. And what we're seeing on the right is hospitalizations. So how many people are ending up in the hospital? And you can see that even though we've just started Omicron, and it usually takes about 1 to 3 weeks after a case occurs for someone to get sick enough to need to be in the hospital, we are just about at the horrible levels we were at last winter, and many of our hospitals have sent out messages this week saying that they have case levels higher than they have ever seen at any time in the pandemic. So yet again, we are overwhelming our healthcare capacity, especially because in the past year, about 1 in 5, so about 20% of our healthcare workers have left the field because they were overworked and exhausted and traumatized. And so now we have fewer healthcare workers trying to do just as much, if not more work this time around. We're in a big pickle, that's for sure. So since we brought up severity, let's just kind of talk a little bit about what impacts the severity of any given illness. And a lot of it is the pathogen itself, the germ itself. There are characteristics about Omicron that make it less likely to deeply invade your lungs and more likely to just hang out in your nose and throat, and therefore it is less likely to kill you. It looks like the case fatality rate is going to be lower. In general, it's not a guarantee it can't kill you. People are still dying from Omicron. It's just statistically a little bit less likely. How much less likely? We don't totally have the data yet, but it's coming. Another thing that's going to impact the severity of the illness is the dose to which you're exposed. So famously in New York City, there was a public bus driver. A COVID-infected person got on the bus. They were angry, they were upset, they were perhaps also not in their right mind, and they purposefully coughed on his face. That gentleman died within 48 hours, right? So if you get exposed to a really huge dose, sometimes there's nothing that your body can do, and you are just going to get overwhelmed. If you get exposed to a much smaller dose, you are more likely to have a less severe illness in general, okay? Then there are host factors. And when we talk about host factors, we mean things unique to that particular person. So age, again, in general, very young and very old, although we've seen with COVID-19 that the very young seem to do okay overall. Not that there aren't severe illnesses, not that there aren't some deaths, but unlike influenza, for example, which can cause a lot of hospitalizations in very young children, we're not seeing that same increased risk in the very young with COVID-19. They still can get sick, they still can pass it to other people, but we don't see that increased mortality rate that we see with some other things. Immune-compromised people, of course, pregnant people, and we're seeing this a lot too. We're seeing some pregnant people with COVID-19 getting severely ill, having other medical conditions, this should all sound familiar, and having some immunity, either from a vaccination or previous infection. And we've talked previously about how protective the COVID-19 vaccines are against severe illness and hospitalization. So when we think about the potential impact of a communicable disease or an infectious disease, there's two parts to it, right? So how serious is the disease going to be, both in terms of the germ itself and those host factors, and then how contagious is it going to be? What's its R naught? What's its reproduction number, right? In terms of how contagious a germ is it, and then what else is happening in the population that might make it easier to infect lots of people or harder to infect lots of people. So we can put things on a scale. So this is a logarithmic scale, and down here is R naught, so average number of people infected by each sick person. So you can see here it goes from 0 to 1 to 5 to 10. And then here on the left is a logarithmic scale of case fatality rate. And you can see that seasonal flu, influenza, has a case fatality rate of about 0.1%. So about 1 in 1,000 people who are diagnosed with influenza will die from that disease. And it causes anywhere from 20 to 80,000 deaths per year on average. Polio is a much more infectious disease than seasonal flu that has an R naught slightly higher than 1, but also had a low mortality rate. This particular graph is from early in the pandemic, and so they weren't really sure where COVID was going to land. So I'll tell you, the original virus had a reproductive number around, I'm going to change my color here, around 2.5, and a case fatality rate around 1. So they were pretty good at guessing. All right, so that was the original one. Now we're in the land of Omicron, right? So we're somewhere out here. It's super contagious, and we don't yet know exactly how fatal it is. So time will tell. I'm hoping it's hardly ever fatal at all. That would be fabulous because a crazy number of people are going to get infected with it. Okay, so for communicable diseases, we have now in part 1 talked about our general concept. So the burden of disease, and it is significant both in terms of premature death and disability, as well as causes of death overall. The different routes of transmission, the different ways you can get infected, how we know whether a certain germ is causing a certain disease, and then we spent a lot of time talking about the potential impact of a communicable disease. And we're going to measure the two variables there. So it's transmissibility. We're going to use R naught, and that's going to be impacted by lots of different things, and then the actual severity or seriousness of the illness itself. All right, so that's it for part 1. I'll see you next for part 2. We'll talk about the tools that we have and our potential strategies.